Hello, my name is Patricia Pozo-Rosich. I am the head of section of the neurology department at the Vall d'Hebron University Hospital in Barcelona, Spain, where I take care of migraine both clinically and research-wise, directing the Migraine Adaptive Brain Center. Today, I welcome you to this touch-in conversation activity where I will be joined by Audrey Craven. Audrey is the president and founder of the Migraine Association of Ireland and is an internationally acknowledged patient advocate for migraine. She serves as the vice president of the European Brain Foundation and is in the steering group member of the International Headache Society's Global Patient Advocacy Coalition. Today, we are going to discuss about shared decision-making between patients and clinicians in regards to migraine, both, I would say, diagnosis and treatment. Because we all believe, Audrey and I, that patients and healthcare providers should work as a team in order to increase both diagnosis, treatment, and reduce migraine burden impact in its quality of life and stigma. So we will start today talking more about burden, the burden of migraine. Just as a summary, migraine is a global, lifelong disease that affects both men and women at, as I was saying, global level, up to a 14%. And that's the prevalence. And it affects slightly more women than men. Women up to a 17%, men up to more or less an 8%. So why are we talking about migraine? Because it has a very delayed diagnosis. It's usually or should be diagnosed by general practitioners, but it's not always, the case. And the diagnosis comes in late, up to 8 to 12 years after the disease kind of starts with attacks which are recurrent in time. And treatment then, that's a consequence, is also delayed both in the acute setting, which is treating migraine attacks, and also preventively, which is a treatment designed to prevent or reduce the frequency of attacks. So here the idea, Audrey, is, as we have you here, which is, I think, such an honor and my pleasure to try and get your feedback representing all of the patients, you could say, that are sufferers. What is the impact that you have, as a patient in regards to the disease? Can you translate this better so that we all healthcare providers understand what patients go through and the impact that migraine has in the family and work life?
Thank you, Patricia. I'm glad to be part of this event today. I think the impact is huge. As we know, and you've already said, it takes 8 years plus to have a proper diagnosis. But the impact and the burden is borne, of course, by the person who lives with migraine, but also their family. And we know from studies across the globe that the first thing to go is their social life. They manage to get to work, although their presentism and absenteeism can be affected. And we know that their career opportunities and further education can be very limited too. And of course, that affects their financial situation. I think it's also very important to understand that most people get headaches. So saying you have a migraine is actually like comparing a flu with a bad cold. And we know that there's a whole stream of symptoms attached to suffering a migraine attack. And I know you're going to explain as we go through the session to articulate just what the burden is and how to recognize the symptoms. And I hope by the end we'll be in a position where we're all more enlightened as to how we can manage and treat.
Yes, indeed. You already have very well summarized this impact. But one thing that I think we have to also kind of differentiate are attacks between interictal, what we say, periods, which actually are many times lived with fear, anxiety, people are scared, no? Audrey, correct me if I'm wrong, you're scared of when the next attack will happen because you actually don't know. It's unpredictable. And this unpredictability, I think, creates all of this burden around the disease, I would say. So part of it is not knowing when the next attack will happen. Part of it, I would say, is this isolation that you have to kind of change, your current status, where you are at. Part of it is probably sleeping. 83% of patients actually report sleeping difficulties. And then, as you were mentioning, the impact that it has in in the whole life. I would say private, so your personal, family life, but also your social and work life.
Yes, and I think it's important to acknowledge that because most people get headaches, recognizing and having an appropriate diagnosis, a timely one, and appropriate treatment is a huge concern. And that is the thing that I think I'm most excited about, Patricia, because I'm a grandmother now, and my daughter has inherited migraine from me, and we know it's an inherited disorder, but we also know that it's a neurological, biological disorder. And it comes with a lot of stigma, and we have a lot of awareness raising to do. So I think getting the message out in this year of 2022 and going into the next decade, things have changed dramatically in the last 5 to 10 years. So that's my key remark in this section, that there's so much you can do. And I think in fairness to the healthcare professionals, they probably dread headache patients coming into their office because they think there's nothing they can do. Well, the key message is, of course, there's a lot you can do, but you must work with your patient in a partnership way, like you said earlier.
Why do you then think that this neurological, as you were saying, disease is not widely sometimes recognized by society, by healthcare professionals?
Yes, I think that's not helped by the fact that there's no test for migraine. There's no blood test. There's no way you can say, that's a migraine, like you can with diabetes or other disorders. So we know that the diagnosis is made by the patient giving a good case history to the headache specialist or to their healthcare professional. And as you would say, and I know Professor Peter Goldsby would say, that a good case history is taken, not given. And so by looking at the accompanying symptoms and recognizing that this is a migraine and that we can help our patient, and for the patient to understand that they have to play their role. And that's where I think this partnership that we have and the awareness raising that we have, and of course you've already mentioned my work with the Migraine Association of Ireland, but in any neurological disorder, it is about being your own best advocate.
Yes, I think that patients need to, or people, we all need to understand that in the future, especially, medicine will not be as paternalistic, and that each patient will have, or each person will have to have an active role in keeping their health, you could say. And that is part of what you're saying now, and providing the right information at the right time to receive appropriate diagnosis and treatment. So you have to also fight to find the right care, you could say, and help your physician or other healthcare providers, nurses, and whoever is in the team help you in a way. What about, another question would be, I'm thinking now, Audrey, what are the concerns for those who have been newly diagnosed? Suddenly you go to a physician and they say something like, oh, well, I think that you have migraine. In general, my quick answer, and you can work around my thoughts, is that, like you were saying, for your granddaughter, she has a grandmother, maybe even a mother or father who suffer from migraine. And probably it doesn't come as a surprise. But imagine in a case where, it's new. Maybe for you it was that way, I'm not sure. But how can you cope with this diagnosis, and what are the first steps to take?
Yes, I think that's a really good question. I think providing accurate, reliable information and reassurance, because of course, when you have a very severe attack, you wonder if you're having a stroke. And we know that every healthcare provider, certainly everyone in general practice, is terrified of missing a sinister headache. So if we have the education piece right, both in terms of identifying what is a migraine and what the symptoms are, and then in terms of offering information, an informed patient is an empowered patient. And what I would say to my granddaughter is that this can be managed. But we know now from research that the migraine brain requires regularity. And that sounds like something rather boring, but in actual fact, we love routine, because if we get overtired, it's one of the triggers. In my own case, I'm an Irish woman who never takes a glass of Guinness because it would give me a migraine attack, and it's not worth that. So identifying your triggers and learning to lead perhaps a more regular lifestyle, because it's not just about medication, I think is very reassuring. And certainly what I'll be saying to my grandchildren, I hope they don't have the life that I've had, because I think things are so much better now. And as I said a few moments ago, even in the last 5 to 10 years, things have changed so much for the better. There's never been a better time to be diagnosed with migraine than now. And really, it's people like you, Patricia, who have made it so. But I think we need to get that message out, and we need to do something about reducing the stigma and raising awareness, and then education, 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 and support.
You're right. Yeah, I many times has happened to me, you know, the experience that I have is that many times, as I was saying, a patient comes in for the first time. They realize, because we tell them that they have migraine, and we teach them. My first visit with someone that I've never met is all about education and making them understand that they have this special migraine. I call it also the migraine brain, and how that brain works, what are its needs. And then I try to manage their expectations kind of around it. So it is interesting to understand, that for many of my patients, that is the big key. First of all, because they feel understood. Suddenly there's someone there that is actually understanding what is going on, because actually understanding how their brain works fascinates them and makes them give, as I say, coping mechanisms and understand what to do. And as you were saying, also, we manage the disease and their expectations as they go by, and they know they have a reference. We are receiving some questions from Italy and Spain. For example, how could we improve the diagnosis and differentiate migraine from other types of headache disorders? And that, in general, I would say that if you follow the classification, there's a fantastic classification that actually has led us to be able to prove in clinical trials and clinical development that therapies work, that they work for our patients. As Audrey was mentioning, we have many more new drugs, treatments that we can offer both in the acute and the preventive setting. And actually, that has been thanks to having a classification. And what is migraine then? Migraine is a disease that presents itself with attacks that actually last between 4 and 72 hours if they are untreated. That consists of headache usually, but not only. They can go also with other symptoms such as aura, photophobia, so bothersome kind of feeling to lights, sounds, and the environment in general. And also it can, if not treated, come together with nausea and vomiting. And that's kind of what the classification says. And with it, you have to be moderately or severely impaired, which actually says that this is, as Audrey was already mentioning, not just a headache. And when a patient has 5 of these attacks in their life, actually, you suddenly are, you can diagnose migraine. What I mean is that probably, or perhaps, we can all have one migraine attack perhaps in our lives, but it is a disease which is made of a lot of these attacks that happen, as we were saying at the beginning, in an unpredictable way that actually lead to all of this burden, impact, and yes, costs actually. It costs us all a lot of money to try and cope with this, mostly at an individual level, but also direct costs related to so healthcare use of patients in regards to the ER, medical, and acute treatment. In regards to our second big section that we want to address today, which is developing patient-centric treatment goals. And that, I think, is one of the key things that will be need to be done in the future. Patient-centric goals, not what we decide as physicians, but what patients are interested in. And we'll talk to Audrey about this. So first of all, just to summarize, I'm repeating it from the beginning, but maybe just to set the scene, we have two types of treatments. We have acute treatments, and those are the ones that we take during an attack. And the primary outcome measure of any trial, which is related to measuring the impact of acute treatment drugs, says that we should be able, or at least try, to have pain freedom in 2 hours. And then, if that is not possible, maybe pain relief. The other thing that we look into is trying to provide a sustained pain freedom and pain relief. So we look into, when we do a trial, we look into 24-hour or not pain freedom, and if that can sustain into even 48 or 72 hours. So we want to control the attack during its whole length. And then we look into, when that is achieved, into how do the other most bothersome symptoms, also kind of react. And that usually is looking into, as I was saying, photophobia, phonophobia, nausea, vomiting, and patient-reported outcome measures, which reflect usually the disability that the attack is having in that patient at that time. Then, on the other hand, we have preventative treatment. And that is treatment which is focused into reducing the number of days, the intensity of the attack, so severity of pain, severity of other symptoms, also the response to acute treatment. So it kind of is as if you're trying to decrease the whole attack and the probability of having a new attack. And when we do trials, what we focus on is measuring the number of headache days or migraine days that get reduced. And that is the first, usually, primary outcome measure. Another way of looking at our primary outcome measures is that we look into how many patients are responding more than a 50%, which means really if you are able to reduce with treatment more than a 50% of the number of days you had at baseline. After looking into this and also looking at all of the measures that I was mentioning, we are very concerned on trying to capture how does a treatment or that treatment have an impact on the patient's life. And we do that with patient-related outcome measures. What do we use? We use the HIT6 for impact, the MIDAS for disability. We have a migraine-specific quality of life scales. Actually in migraine, we have many PROs that actually are focused on trying to answer these questions. But maybe we should, start thinking about what, Audrey, what would be, at least for you, or, I know you represent not only yourself, but many patients that you have worked with during your whole life. How could we focus on finding the right, what is for you important? What would you put in the top list when you're, for example, taking a drug acutely and preventively? Can you dissect this for us?
Yes, well, I think functionality is probably the number one thing for me, that there are days when I could function at a low level, but certainly participating in a webinar like this would probably be beyond me because of brain fog and being unable to function. So I would put functionality right at the top. I think perhaps also maybe managing expectations, because we know that, for instance, you mentioned the guidelines, and we know that chronic migraine is currently 15 days, 15 attacks, 15 days per month. Now that's half your life. I mean, that's a very, very heavy burden. So of course I would be motivated to take prevention. If half my life is placed in a darkened room, isolated, unable to function, of course I would. And I would willingly do it. But I would only do that probably with somebody that I trust, and somebody who's prepared to come on the journey with me. And that's where I see this collaboration and this partnership working. And that's why I'm so committed to patient empowerment, and why I'm particularly interested in patient advocacy, because we have to be our own best detective. And, you know, we have to make sure that we articulate it, that we keep a diary, that when we go and we finally get to see somebody with your skill set, one of the best headache specialists around, that we are prepared, and that we don't waste your time or ours, and that we ask the right questions, but also that maybe you give us that little bit of extra time, but also that we're focused. So there's a capacity building role for us as well, that when we go, we're prepared. But of course, we know it's in my best interest and the best interest of all who live with severe migraine. And I've spoken to people who've had one migraine attack in their whole life, and they've never forgotten it. Never. Well, and imagine having that 2 or 3 days of every week, but you don't know which days of the week. So you don't know if you can go to work. You don't know if you can mind your children. You see it all
absolutely.
the time.
Yeah, you're absolutely right. I was saying that you're absolutely right that the current patient-reported outcomes are focused more on kind of the negative effect in a way. So we measure disability, we measure the impact, but we should be probably focusing on finding a scale that actually measures function, so positive. How much are patients able to go back to work, to do their life, to live without fear? Many times I've seen with treatments that patients actually are really appreciative to just having an attack that responds to treatment, you know. So actually they're happy already when they know that at least they can control the attack. So control, go back to function, and then understanding that we are doing all that we can. So they realize that we are putting everything that is out there available for them in every regard. I think this support, as you're saying, is also probably one very meaningful thing for patients. So the other very important thing that we will have to work on, Audrey, you know, in the future, as far as I see it, is to try and understand that every patient is different in a way, and that migraine is a lifelong disorder. We should probably be working also in understanding how treatment goals might change during life, and how can we best adapt to you as patients along your life. How can we as healthcare providers give you support during you know, all of the different, I would say, challenges that we all have during life in general?
Well, I think good communication is top of that list. And also by perhaps giving an explanation. And I noticed one of the questions that came from Italy was explain the pathophysiology, depending on the level of interest of the patient, to explain this is a brain disorder, this is what you can do, this is what we can do. And as you say, the support, a little bit of hand-holding, especially in the early days. And the other thing I think which is pertinent to your question, we know that migraine can change over the life cycle. So, for instance, I know that in the early days, when I began to suffer really severe migraine attacks in my 20s, I quite frequently, because I would be vomiting for so many days, ended up in the accident and emergency of the local hospital, of the main hospital actually, near where I live. And of course, I was dehydrated, but with good information and knowing what is happening to your body and carrying medication on my person and having an understanding, for instance, just by way of absolute demonstration in being here today, the light for the camera was just too bright and it induced early migraine symptoms for me. Now, thankfully, they're very understanding here and we're able to do something about it. But I actually asked and articulated that that was an issue for me. For some people, getting the courage to do that is quite difficult. If you're in the workplace, you do not want to be seen as a neurotic malingerer. You want to make sure that you're pulling your weight at your workstation. But equally, we know, and from my work with the Global Patient Advocacy Coalition, we have a workplace program, and that is designed to help employers understand that the person that they're employing can be a very highly functioning person, but they may need to withdraw for an hour or two before they return to their workstation. So all of these things are important throughout the life cycle. And as you have said, we know that it affects people, predominantly women, but it's during your work life, at your younger phase, that it's more prevalent. So we have a real responsibility there to try and make a difference in the workplace and in schools, teaching young people how to manage their headache and not becoming dependent all the time on medication, perhaps good lifestyle issues. Now, that's hard for young children, and I accept that.
Oh, absolutely. I was thinking on a couple of things you were mentioning. The first one would be, so what does a patient want to understand about their brain? And my personal take on that, after visiting a lot of thousands of patients, I would say it's the why me. You were saying we know it's an inherited disorder, and explaining that concept is fundamental. Then the other thing is why now. You want to understand, why does this start now? Why do I have an attack now? It's, as far as you can correct me if I'm wrong. Maybe the other thing that I've realized that patients want to understand is like, why here? Why is it here and not there, and why with this intensity of pain too? And then finally, I would say that people want to try and then find out, with all of this seen, what can I take, and what is the right treatment for me. I have to say, you were mentioning before the fact of trusting your physician in order to start preventive treatment, Audrey. But in my opinion, personally, at least probably because I see the most affected and impacted patients by the disease, is that the best acute treatment is a good preventive treatment, because the whole symptomatology of the attacks is actually better, treated, you could say. And there was a question here in regards to how can we then manage chronic migraine for patients, what to say to them.
I think if you make a decision, a shared decision, you're much more likely to adhere and comply and be part of the program and adhere to it and stick to it. And I think a reduction in severity and frequency is a huge step forward for people. Going back to the chronic migraine half your life, if you went even to 10 days a month or 12 days a month, that would be absolutely a plus. So maybe those incremental steps with your patient being the partner is really the way forward.
The next section that we're going to treat, Audrey, or talk about, is actually shared decision making, which I think is very important. And to have you here and be able to talk with you around this is going to be, I think, also very enlightening. So again, what can we offer our patients? We have episodic migraine treatments, both in the preventive settings. When I mean episodic migraine treatment, it means really that they have been tested in a clinical development for episodic migraine. And then we also have treatments that are more specific to chronic migraine. So what would be probably the first line of treatments? I would say in the acute setting, NSAIDs, so anti-inflammatories, and I would say, in my opinion, also triptans. I would say they're a first-line treatment. I mean, if you, they've been 30 years out in the market. And actually, for example, I do a lot of, I'll ask you, Audrey, what is perhaps, what are your thoughts on that? But I combine also. I share with my patients that probably it's even better if you can take at the same time an NSAID and a triptan and don't kind of do a sequential treatment, because there's a window, a therapeutic window, where you want to actually treat patients quickly before the attack gets uncontrollable. And then there's new treatments coming in, and they're, it's really exciting, Audrey, because we have coming to Europe very soon, but in some countries already being approved, especially in the United States. They go a bit faster than the European approvals, but we already have lasmiditan coming in. That's a ditan, so it's a bit different from the triptans. It has, so it's specific to the serotonin 1F receptor, and that actually acts centrally. And for many types of attacks, I will say that it will provide different approach. It's also safe. And then we have the GPANs, which actually are focused on blocking the effect of CGRP, which this peptide, the calcitonin gene-related peptide, which is a pro-inflammatory neuropeptide, you could say, that is very prevalent in migraine and which increases during attacks and is increased more in chronic migraine patients than episodic migraine patients because of all of the amount of CGRP that you keep on producing day by day. And then we have, the preventive treatments. And as I was saying, there are some mild differences between episodic and chronic. However, I would say that nowadays, at least in most countries, you could say standard oral preventives probably would be the first line. I'm going to give some examples. Beta blockers such as propanolol, metoprolol, any beta blocker probably could work. Topiramate, but also candesartan, lisinopril, and in my opinion, anti-CGRP antibodies actually have proven to be effective in patients who have 4 or more days of migraine, but are reimbursed in many countries when you have 8 or more days of migraine. That changes depending country by country, I would say. So it is important to remind ourselves that we have therapies that have been developed for migraine nowadays and that should be offered, I think, to patients sooner than later. And then we have all, which is kind of surrounds this, which is patient-centric, I would say, which is understanding all of the, how can we actually provide a good quality of care that actually has an impact on how the patient gets involved in being adherent to the treatment, in helping you help them with, following headache diaries, answering all of the PRO measures that we kind of sometimes use, because that helps us help them. In order to understand whether if a treatment is actually being useful for a patient, one of my favorite scales or PROs to use is the PGIC, which is the Patient Global Impression of Change scale. It's a very easy scale that actually we have proven that works in order to measure whether if a treatment is working or not. It's a 5-item scale that, you just say if the patient answers back if they are better, more or less better, the same, or worse. And that actually gives you a lot of information, very basic, but ask, the patient about it. And it gives you information, as I was saying, on how the patient is receiving, and having an impact on their treatment. So Audrey, in regards to, this shared decision-making approach in migraine management, I would say that perhaps in this section, we can perhaps think of what would be, as a patient, other things that I have not mentioned that for you would be important for your healthcare provider to share with you. Anything that I have forgotten?
Yes, I think you've covered a lot. I would say that I think it was mentioned in one of the questions, the gut brain. We know that our stomach, I think it's called gastric stasis, and therefore taking anything orally is quite difficult. So I use Motilium together with the first line defense always, because for me, unfortunately, vomiting very much comes with the migraine attack. So the subcut of the triptans that you referred to there, the subcut is very important for me because I get to the vomiting diarrhea stage very quickly. And I think for a lot of patients, that's a very quick delivery. Also, I think looking at the patient holistically, we talked a little bit about lifestyle changes, but we know there's a lot of research now in terms of slowing our mind down, mindfulness. I have found a particular acupuncturist has helped me when I go back if I'm going through a bad spell, and I found that makes a difference for me. But as you said, it's very individual. So keeping either an electronic diary or a paper diary, whatever suits you, so that you have something to compare with. As humans, we're programmed to forget pain. I always say there would hardly ever be a second child in a family if we weren't. But I think in actual fact, when you go to your healthcare specialist, your healthcare provider, and you can say, last month I had 9 days of migraine, whereas the previous month it was 12. That is a significant improvement. Okay, it's probably too early to see a pattern and something, but you do need something to help you to manage it. So that's, to me, what that would look like. And also, I think being mindful of the fact that we really have to work in tandem with what's available, and also be very careful about how we phrase concern. For instance, if somebody's attitude is very dismissive to you, you are hardly going to say to your healthcare provider, well, do you know, these headaches are really bothersome and they're getting between me and my partner, or they're getting between me and my work. They're not going to confide that piece of information to you. So I know everybody's busy, but I think the good communication, being empathetic, but also working on a treatment plan that is shared is definitely worthwhile. And then setting the goals and reviewing them together so that we have a record as well.
I just have a quick question. Do you think, I agree, headache diaries are for me very useful, but do you get tired as a patient of filling in the diary? Does it just, is it, very burdensome actually?
Yes and no. No, if the burden is if your functionality is very poor, and you know that you are partnering with your healthcare provider, you will have the motivation to do it, because you know this is in your own best interest and it is impacting greatly on your life. When we get better, we don't even want to mention it.
Yeah. No, I mean, you're a good patient, I have to tell you. I mean, most of my patients are good patients, very involved patients. I do sometimes have some that actually don't want to fill in the diary. They feel, they're just, when that happens, I usually say, just if you want, especially for chronic migraine patients, just fill in the days where you feel well, so do it in the positive way, and don't keep on just, crossing out days that are days where you don't feel well, or you are, with migraine, and that sometimes helps too. But yeah, usually my patients are quite compliant. Sometimes I have some issues. In regards to success, when would you say that you are happy with a treatment? I can think of ways, but I'd rather have you say it. What is a successful treatment for you?
Well, I think a success to me is being able to lead some sort of a normal life, where migraine isn't lurking over my waking moment every day and being able to get on with my life. That's what success looks like. For others, it might be being able to take care of their young children. For somebody else, it might be getting up and going to work and holding down a career. I think really what you want to make sure is that your life is improving, that you're making progress. And if you have setbacks, which undoubtedly you will, and I think we haven't mentioned the menopause, but I know for women that can be a factor. So, you know, you've had 25 years of migraine and now you're back into a very, very bad cycle. That's where I think the trust and the support that I see patient organizations giving accurate, reliable information and reassurance that we'll get through this, but we'll get through it together. You don't have to go through this on your own. We can help, we will help. But that is the road to success, as I'm living proof of, because I know that things can get better, but it didn't feel like that at the time.
Yeah, no, I think I would have said the same thing. I think it's partly, and there's a question here also that is tackling this problem, and we have kind of mentioned it, but maybe we can deep dive into it, which is the fact of fearing, fear, living in fear, kind of not knowing when an attack is going to happen. I think that you really have to have, as you were saying, a lot of resilience and work through it. Sometimes during life, I'm hearing you too, in the sense that during life, maybe you need to go to different support systems or people that actually support all of the doctors and nurses, in the sense of, as you were mentioning, acupuncture, but sometimes also maybe a physiotherapist I'm thinking of, maybe a psychologist sometimes. And it keeps on, it doesn't mean that you will be always on that therapy for the rest of your life. But as you're saying, in the most stressful moments, it's finding the right circle of trust, you could say, of different people around you that can actually help you make it through certain periods of life.
I suppose one of the areas is your first port of call as a person living with severe headache, which mainly goes undiagnosed, untreated, mistreated, and undertreated and mismanaged. You go to your GP, your general practitioner. And I think that how do we make sure that we get a diagnosis from them? So we have a big piece of education to do, I think, on that front. Or going here where I live and in these islands, people would go to their pharmacy. And we haven't mentioned it, but the other thing, of course, is that people can overuse medication. And that's another issue around education. So if you like, those are the areas that I would just like to mention as we're drawing to a close, because I think they're key for people living with migraine and how we can be very aware of what is happening to us, but also how to manage it, but not getting into more trouble by overusing medication, as I'm sure you see a lot of patients with that. But that's perhaps a topic for another day.
Exactly. There's so many questions, that now I'm thinking of we should probably be talking about, and very interesting questions too that we are receiving. But we have, as you're saying, no more time for today. I really hope that you have all enjoyed, our conversation. Audrey, first of all, I would like to thank you for this very interesting, as always, insights into your experiences, your life as a migraine sufferer, and how has that impacted your life. I thank you because it is very, very hard for patients to, what I call, come out, and actually be so honest on how much migraine has impacted your life. And I think that your long-standing efforts in advocating for migraine are very much appreciated by every one of us, at least in the field of headache. And so, as I said, thank you for being here with us this afternoon.